Healthcare Economics Advanced, presented at a summer camp, summer 2014, with new narration added summer 2018, by Edward J. Harshman. This presentation is intended to be timeless. It omits details of the PPACA, Powerful Politicians Achieving Catastrophe Act. It ignores the overrated buffoon always mismanaging America, Obama for short. First, the definition of health care. Is it offset of deterioration or a positive service? Offset of deterioration equals bring me up to standard of before deterioration. Positive service equals something tangible is being done. Here are examples of offset of deterioration. Hunger, offset it with food. Cars and gasoline, same idea. Danger of thinking offset of deterioration. If there is a standard to which people are to be brought up, then there is a tendency to think of achieving that standard as a right. Positive service. I want or need something, so I must pay for it. Whoever provides health care wants to get paid. Whoever receives it can be called on to pay for it. On to macroeconomics. It is based partially on the false assumption that people's well-being requires measurable economic activity. To understand health economics, including supply and demand, we must look at underlying fundamentals. Macroeconomics is the study of those measurable things that affect an entire economy. It's misleading and irrelevant. Macroeconomics includes measurements of economic activity. But economic activity is not the same as wealth creation. Here's proof. Look at the refrigerator and the iceman. Many years ago, we had ice boxes. They kept things cool and were powered by blocks of ice, which had to be replenished daily. There was activity of harvesting the ice in winter, storing it, and delivering it. Nowadays, we use refrigerators. Buy one refrigerator, and it lasts for years. We pay less for the electricity to run the refrigerator than we would pay for daily ice deliveries. Macroeconomics says we get poorer, but consumers benefit. Consumers benefit from the changeover from iceboxes to refrigerators. That's why we use refrigerators. Macroeconomics says there is less money being spent, so we get poorer. But we spend less, so instead we get richer. What of the displaced icemen? People who would do ice deliveries are working at something else instead. The something else increases total wealth, so that on average we are more prosperous, not less. Another example. A car crash causes car damage that must be repaired. Economic activity results. Loss of value to the car is not subtracted in normal economic analysis. Attention paid only to activity. Work done to repair the damaged car or to build a new one could have been prevented by preventing the car crash. But the outcome of the crash is that some auto workers had some work, and some car owners and insurance companies had to pay for that work. And the total wealth of everyone is more or less unchanged. The value of the new car may be greater than the value of the smashed-up one, true, but the increase of value is less than the resources expended in the repair or replacement by the loss of value caused by the crash, and macroeconomics ignores this fact, confining its attention to the materials and labor used. Other examples of consumer benefit that macroeconomics ignores: plant a garden, grow vegetables, and spend less in the supermarket. Home theaters instead of buying tickets at real theaters. Measured income drops, but value to consumer does not. Yet another example is the recent trend to doing things oneself, not hiring someone to do them for you. Convenience foods and home repairs. Doing things oneself also, legally, dodges income and payroll taxes. This analysis is important because liberals tend to look at economic activity, not true wealth, when they analyze something. They also favor government regulations if those regulations will create physically easy desk jobs. To liberals, economic activity, including plenty of physically easy desk jobs, is a good thing. Prosperity is a good thing, but interfering with the way businesses operate, thereby making them less successful and more likely to lay people off, is not. We finally turn attention to healthcare economics. What characterizes the best healthcare? Low cost to the patient, high revenue to the doctor, nurse, hospital, etc. Therefore, as little money as possible is diverted on the way from patient to doctor. In reality, this simplification does not work because regulations convert doctors and nurses and hospitals into adversaries. Liability issues and insurance make a mess. Doctors are under pressure to toss patients out of hospitals quickly. They also can be sued by patients who are discharged early. Hospital bylaws protect the hospitals. Because of HCQIA, which stands for Health Care Quality Improvement Act, but which I call the Help, Censor, and Quash Innovation Act, doctors can be fired for not cooperating with implicit demands by hospitals, expressed through innuendo only and not clearly stated. Hospitals can not only expel doctors from their own hospitals, but also can make them unable to get work in any other hospital, therefore perhaps any medical work at all. Meanwhile, nurses get heavier and heavier workloads as hospital bosses demand more from them. With convalescent patients getting discharged sooner, the average inpatient becomes more ill. Regulations are complicated and voluminous, facilitating errors and increasing costs. They change often. Hospitals often have at least one full-time administrator whose only job is to keep up with the latest changes. Major penalties exist for errors, but the regulations are so cumbersome that accidental errors are unpreventable. Selective enforcement can occur. A penalty may be enforced vigorously against a doctor or hospital with a new method, but not against a doctor or hospital with political influence who blindly obeys dogma. The process of learning regulations and figuring out how to follow them thereby cuts into revenue for providers. This process is separate from the direct cost of actually following the regulations if they are assumed to be understood. I suspect that part of the motive for the complexity of the regulations is to make sure that no one can understand them completely, thereby making every healthcare business certain to violate something frequently and allow politicians in power to attack their enemies. Low patient cost. Educate the patient. Dentists say brush your teeth. They don't send someone to your house to brush them for you. Health education in general is missing from school education. The Internet gives access to information so that patients can keep their costs low. The FDA, which officially stands for Food and Drug Administration, but which I call the Fool and Dunce Administration, prevents dissemination of many true statements about natural remedies. Schools do not teach how to identify a destructive potential boyfriend-girlfriend. Psychologists are paid better if there are many interpersonal messes to clean up. The FDA prevents some treatments entirely, even if people would be willing to pay for them. Intravenous hydrogen peroxide in ambulances would save lives when lungs or circulation are damaged, as by a heart attack. But hydrogen peroxide was banned as an internal substance before many modern techniques were developed. No one will pay for the studies to prove that it works. Meanwhile, The FDA won't permit its use despite invincible evidence. Gangrene from Clostridium is serious and can be fatal. Clostridium, a bacterium that dies when exposed to oxygen, will be killed by hydrogen peroxide and cannot develop resistance. Hydrogen peroxide was restricted to external use only before modern techniques of putting substances into arteries were developed. I lost my brother to that infection and remain very upset. Setting aside the FDA, hospitals themselves prevent other low-cost competition for the treatments that they offer. An example is EDTA chelation instead of bypass grafting, $4,000 versus $100,000. State medical boards also interfere with progress. Effective and low-cost treatments damage revenue streams to the medically organized relying on nonsense, morons, entrenched establishment. Harassment of smart and non-conforming doctors by medical boards is a well-recognized problem. Health care regulation is a hidden tax. Insurers practice price discrimination. Medicare is legal price fixing for the elderly. Low Medicaid payments encourage providers to raise prices against other customers. Providers default to charging more from the privately insured and still more from the uninsured, who have no bargaining power and are often poor. Price discrimination is unfair to the uninsured ill. If the healthcare establishment needs tax money at all, then the healthy can earn it more easily than can the chronically ill. Insurance is intended to offset major unpredictable expense. It can also be a bargaining agent if providers sign contracts with insurers to accept the insurance's price lists as the full amount that they will charge. Asking prices for doctor visits, hospital stays, etc. are usually greatly inflated. The uninsured are thereby badly cheated. Doctors and hospitals expect to get much less than they ask for. They usually accept the insurance pricing. We the people want low prices. Of course, doctors and hospitals would benefit from high prices. But who benefits from high nominal, high asking prices? Unions. They want to threaten employees with high prices unless the employees join a union. Big employers with insurance plans also. Their jobs become more attractive with less labor expense if they can promise low health care cost to their employees that they cannot get anywhere else. Liberals. They can't claim credit for giving government relief for high health care prices if health care is inexpensive already. Rich liberals. They won't mention something at social gatherings that might cut into someone else's income. Why anger a hospital president buddy? Insurers as negotiators. A legitimate role. Unscrupulous providers exist. Preventive services are predictable and are not insurable because they are not risks. Insurers should be forced to offer their negotiated prices to all patients who will pay them, plus a fee for the negotiation. A provider who will accept a bargained down rate from one patient has proved willingness to accept that rate from all patients. An insurer can take a payment from an uninsured patient, pay the provider the bargained down rate, and keep a small administrative fee for processing the payment, pretend to the provider that the patient has insurance, and thereby save much money for an uninsured patient. That way, no discrimination can occur and prices will become transparent. If insurers have to offer their reduced prices to anyone who pays, then price discrimination stops and competitive, low prices become the norm. Also, Medicaid can receive big money by charging negotiation fees. Healthcare provider payments. Goods versus services distinction is wrong. Hire a taxi, rent a car, lease a car, buy a car. Where on this continuum does a service become a good? A better distinction is between low overhead and high overhead. Low overhead job, house cleaner, needs little education. High overhead job, astronaut, needs education and physical training. High overhead requires major expense to prepare for the job, and the effects of the expense last for years. A high overhead job does not necessarily pay well. Investing in high overhead job creation requires expectation that the job will exist until the useful life of the investment has ended. Medical education is a risky investment. Medical education is risky if hard bargaining may later reduce prices to cover variable cost only. Fixed cost in medical education may be a total loss. The risk will discourage investment in healthcare education by medical and nursing students. A long-term shortage may occur and years will be needed to correct it. If there is no measurable shortage, watch out for deteriorating quality of the doctors and nurses. It's there. Smart people who understand this reasoning will be scared away from healthcare. The profession is being dumbed down already. The very best and brightest will be deterred by the riskiness of the investment in medical education. A related but different deterrent is the need of physicians to conform to existing doctrines and dogmas and never challenge even obsolete or dangerous ways to care for patients or orders from administrators to let patients die or otherwise do wrong. Our activist allies in healthcare won't put up with such garbage, which means they won't bring their skills to the fight for healthcare freedom. Dual reimbursement model. Structure of how to pay for healthcare. Suppose you are a physician and are offered a fee-for-service contract by a local factory. That means high revenue if many patients seek your services, but a potential heavy loss if few or none do. Or suppose you are a physician and are offered a fixed fee per patient per year for some people on a known list. But you risk taking a very big loss if there is an epidemic or a similar major need for health care. But if you accept both offers, and if the demands of patient categories go up and down at the same times, then your overhead is guaranteed, and the more you work, the more you get paid. Here's the key principle. If the variable per patient encounter revenue exactly offsets the per encounter expense, and the fixed revenue offsets the fixed expense with a reasonable profit left over, and the contract lasts as long as the fixed assets, the contract between payer and provider can be assigned but not canceled, then the medical practice has zero financial risk. And if the medical practice has zero financial risk, then the on-average amount paid to the provider for a given amount of work and of risk for work that might occur is as low as possible, because healthcare workers don't need to be paid extra for risk. Inference from this analysis. To minimize payments for healthcare, structure them so that fixed and variable costs are separately calculated and paid. This protocol eliminates risk. No one needs to charge for it. By reducing the monetary risk that the doctors and hospitals accept, the amount that they are willing to accept as fair payment is kept as low as possible. So far, I said nothing about who pays, but the analysis of how to keep the expense as low as possible is valid regardless of who pays. Investors, ordinary patients, etc., can sign contracts to pay a fixed fee monthly in exchange for a finite amount of care at variable cost only. This contract is an agreement to provide a service. It is not insurance. It is theoretically possible for a healthcare investor to make a deal with doctors and hospitals to buy the right to obtain specified amounts of care at a predetermined price. The right will be transferable. Then you buy what you think you will need, or you buy from a healthcare investor if you prefer. You can make deals as you wish with doctors and hospitals and pay them directly if you prefer. It's not required. If you buy too much healthcare, you can give the excess to charity, or just plain sell it. Right to purchase arrangements can be designed by insurance companies, cooperatives, or pretty much anyone. This system allows shrewd patients to buy healthcare scripts and maybe make a profit from them. There is no reason not to allow such speculation. See airplane overbooking and damages paid to consumers, for example. It's a better deal for airlines if they risk paying damages for overbooking a flight than risk too many empty seats instead. Of course, most healthcare will be bought at first by insurers and major investors, and insurers can decide what to cover according to what the free market says. If ordinary people can buy and sell healthcare script for a profit, why not? The bond underwriter scam. Many protocols keep money from the public. Stock and bond underwriters often cheat the stockholders. Big corporations hire underwriters when they sell big dollar issuances of securities. Corporations could instead give stockholders options to purchase such stocks, bonds, etc. That way, stockholders and not underwriters get the unpredictable profit when their offering is priced slightly too low. Stockholders would thereby get their profits by selling their options on the open market, or using the options themselves by buying the new stocks or bonds at below the open market price. The small investor should get that money. To the airlines, penalty fees to bumped-off airline customers are worth risking. Underwriter fees can and should be diverted to the stockholders when offerings are made. There is no intrinsic prohibition against ordinary people's investing in healthcare. The culture of investments and finance tends to frown on allowing ordinary people to acquire money through speculation. This attitude is selfish and disgusting. Insurance, technology, and the death decision. Health insurers are trapped by changing risk. Buy a bigger house or car, and premiums go up. But if medical technology changes and regulators don't react, premiums don't go up. To live or to die if you are seriously ill or injured. That's between you and God. You and God have a personal decision to make. No death squad in the insurance company has the right to condemn you to death, and no one is required to keep you alive. People have willingly fought and died for our freedom. They valued freedom more than their lives. It's immoral to confiscate someone else's freedom to pay for care to keep you alive. Otherwise, the very foundation of our liberty is destroyed. That attitude sacrifices freedom. Freedom includes the freedom to keep what you earn. Rescinding that freedom is essentially equivalent to enslavement. If heroic measures to prolong the life of someone terminally ill are expensive, then there is no intrinsic duty of the taxpayer to pay for them. Responsibility that should be individual is being dumped on the government. The doctrine of paying to keep other people alive, other than as a personal and individual voluntary response to begging, is not consistent with Christianity. Proof follows. See the prodigal son, for example, Luke 15, verses 11 through 32. In the prodigal son, the father did not look for and rescue him. The prodigal son returned broke and begged for a servant job. The father said to the loyal son, "All that I have is yours." There was no reapportionment of assets to benefit the prodigal son. There was no forcible transfer of assets from the hard-working son to the lazy spendthrift. The father did not seek or worry about the son who ran away with his inheritance. The irresponsible must pay their way and do without any protective oversight, even if death were to result. So says Jesus. Patients should be free to pay extra for specified services, or to not pay and do without. One-size-fits-all insurance is unreasonable. Different people have different attitudes about risk and insurance. If you make a decision to accept low insurance payments, and some risk that an uninsured expense will go unpaid and you die, then you have made a business decision. If you later acquire an expensive illness, then you will die with honor. If you will die with honor, then you won't drag down anyone else. And if death worries you, then plan ahead at your own expense. You decide. Government does not. Liberals hate this reasoning. They are too lazy spiritually to make the decision as individuals. They do not pay attention to God. They do not want to consider death. They also have a tendency to make decisions based on mood. They expect forgiveness if they encounter unexpected major stress. They rely on the nanny state. We live in a world of safety nets. Emotion-driven decisions of feel-good liberals don't cause natural consequences. They get the glory, we the taxpayers feel the pain. If the government surrounds us with safety nets, then the nets turn into cages. Many poor people ask for money for health care or for insurance. But they can pay for alcohol, cigarettes, junk food, big TV sets, mobile phones, and other items not needed for life. Watch the response when you offer money to a so-called poor person in exchange for a promise to do without such things. Expect anger, not understanding and cooperation. Question: what is the most common setting in USA life in which material aid is offered in exchange for lifestyle restrictions? Answer: prisons. The problem of pre-existing medical conditions can be solved easily. Bonds are bought and sold all the time, while investors make decisions about the relative value of a large sum of money, and the right to receive smaller periodic payments in exchange for that large sum. Health insurance premiums are periodic payments, and the financial calculations that derive the prices of bonds can be applied. More specifically, when a seriously ill patient seeks insurance, insurance companies can use their information about monetary risk to figure out a fair premium for such a patient, which of course will be higher than the premium for a healthy person. The increase in premium that results from having a chronic condition can be translated by standard financial calculations to a lump sum. Make the old insurer pay the new one that lump sum. Except for the uninsured seriously ill, the problem is solved. Insurers won't be so quick to harass away ill patients if they must pay to do so. And insurers will receive big money to care for the ill and won't mind doing so. Abandoning care and collecting the lump sum can occur. Let heirs, not insurer, get the money if a patient surrenders care and allows death. This protocol reduces the temptation of an insurer to bully patients into dying. Interlocking ownership and the problem of imperfect capitalism. Of course, drug and insurance companies will resist health care overhaul that will cut into their revenues. but the surprise here is that many other corporations have a concealed interest in the same resistance, even if they are not in the healthcare or insurance businesses. If most of the stock of a corporation is owned by pension funds and other aggregations of stock that also own stock in drug and insurance companies, then the stockholders will tell the corporation to self-sacrifice to the drug and insurance companies, maximizing stockholder wealth even though the corporation itself thereby becomes less profitable. It's also a problem in education. Teachers' union pension funds are invested partially in healthcare. Teachers therefore have a money incentive to not teach their children how to not need to pay for healthcare. The consequences of interlocking ownership look very much like a conspiracy. Big business and big government seem to coordinate as if there is an unseen mastermind at work, even if there isn't. What free market change in federal law will help solve this problem of interlocking ownership? Hint: it will make legal and enforceable a voluntary decision by corporations. It won't force anyone to do anything. Answer: legislation that allows a publicly traded corporation to require all of its stockholders to not own any stock in competing industries that it specifies. The prohibition on competing industries is probably more important than competing corporations in the same industry. If a corporation does not compete against other corporations its stockholders own, then it will not be dragged down from genuine innovation and improvement by large blocks of stockholders with conflicts of interest. Example of how this legislation might work: a car manufacturer says don't own any airline stock. Then improvements in car manufacturer technology and the outcome of making lengthy driving more comfortable and cheaper will not upset any of its stockholders if airline profits go down. This remedy in healthcare may reduce total corporate profits if one healthcare corporation can improve itself. But if total corporate profits go down for the same amount of consumer benefit, then the consumers get richer, not poorer. In healthcare, insist on putting the citizenry first and tell mutual fund managers to consider selling drug and insurance stock. Then any corporation not sharing ownership with healthcare entities can work freely to lower healthcare costs. There would also be much less pressure from pension funds and such if we could abolish the income tax and the need for such financial instruments. Without the need for tax-deferred investment mechanisms, mutual funds and similar investments would become less popular, and individual investors would be more likely to consider each corporation on its own merits. Watch also for corporations that want the cost of health care to be high, bullying workers into taking very low pay to get protection from overpriced health care. Big labor has a similar motive for high health care prices. This reasoning means that we cannot simply entrust our financial assets to someone else. We have to make our own decisions, invest in drugs or invest in cars, not both. The price of freedom is vigilance. Pay it. We need reform in education. Schools need to teach the fundamentals of physical examination, safe and effective home remedies, simple methods to manage interpersonal conflicts, and other health-related issues. The emphasis on sports, including competition, is totally indefensible. A school child is more likely to be confined to a wheelchair than to be a professional athlete. Where are the wheelchair sports? If a child gets practice using a wheelchair, then that child will acquire compassion for the wheelchair-bound disabled, appropriate fear of hazardous activities, and intolerance of the genuinely but partially disabled who use their impairments as manipulative props to extort money or favors or other undeserved benefits from employers or from society at large. Ask school officials why, given that being identified as not smart, therefore getting a bad grade is a bad thing, Open competition in athletes so as to highlight the clumsy is officially celebrated and welcomed. Continuing medical education keeps physicians up to date. But who decides what is proper information for that purpose and what is not? If health material is useful for physicians, then it should be approved for continuing medical education credit. Such approval should not be conditional on the ivory tower status of its writer. The American Medical Association is involved in approving continuing medical education. Do not think it will permit being bypassed if someone offers a CME course that reduces revenue for physicians. Adult education should be available in public schools for people who want to learn how to take care of themselves. I found it difficult to offer such a course, got a hostile reception at the local high school, and had to give up. How to fight back. Don't give money to the enemy. Get a high medical expense rider on the car insurance in case of car crash injuries. Eat right, exercise rationally, and keep your living quarters safe. Reduce the risk of needing medical care to begin with. Use medical tourism. Go bargain hunting. Use naturopaths. Get free from prescription drugs. Avoid mental illness. Stay away from people with destructive personalities. Beware social pressures. Watch for brittle cordiality and an apparent need to conform. Brittle cordiality is what I define as politeness and pleasantness that has an undertone of a threat, a sense that if you do not cooperate with what the person wants, then sudden anger or another bullying or punishing behavior will occur instead. How boys and girls, later men and women, should interact with each other in ways that screen out abusive relationship partners is totally ignored in school curricula. Learn these concepts yourselves. If entrenched interests, such as high-status jerks in school, give you a hard time, then treat such incidents as medals. Brag about them. They show that you are not subservient to a corrupted society. Keep government out of health care. The end.